here, and care coordination and payment for those services, I think that's where you can funnel that to continue to fund these community health workers. Just sharing, that's all.
Thank you. Thank you for that. Other folks, and again, can be questions, or you can share your experience or an answer to one of the questions that was posed.
I just want to follow up on the previous comment, because I think it's really important. One of the challenges I think all of us face is to know who needs what service. We have limited resources, we have budgets, right? And the question is, so you have a panel of folks, some of whom don't need anything, right? Some of whom need something. And that something might be some sort of patient portal, that if you have an electronic health record that has that functionality, you can reach out to folks electronically and you can do that. Some people may need a little bit more than that, maybe a Skype visit or a telehealth visit of some kind. And then there are some people that are going to need to have somebody come to their home and visit them. But knowing who needs which of those things is a huge, huge challenge, because if you end up sending people out to the home for folks who don't need it, that is a waste of resources that we don't have. And if you end up not getting to the proper thing, that's also a problem. So I mean, I applaud the folks out of Stony Brook, because you have to study this. You have to do it, and you have to see, well, what kind of a result are we getting for what amount of resource commitment to which group of people? And and the fact of the matter is, those are findings that do not have to be generalizable. You don't have to know whether or not that's going to be true for everybody. You only have to know if it's true for the people you're dealing with. And that's fine, because that's what, that's how we have to manage this in order to not run out of money.
Great. And our last question?
Isaac from one of the things that strikes me is that the patient-centered medical home works really well for people that are sort of organized. And it really doesn't work very well for the people that are not really very organized. And that's a smaller percentage, but that percentage is the group of people that take up or make up the large expense. Perhaps they're the high utilizers. Mm-hmm. One of the things that I feel like there's an opportunity right now is in a public health initiative to try to engage people in managing their own illness. Because all of these interventions that have been taking place are really focusing on the provider end of things, and and I don't know if those people necessarily will be the ones that would respond to a public health campaign, but everybody else would. And there's no billboard in the New York City subway about patient-centered, your responsibilities in a patient-centered medical home. I think, so for the Department of Health, perhaps you might consider it.
So great question. So we didn't talk about or specifically call out patient engagement strategies or how to do that. Dr. Singer did talk about some of that, I think, in his plenary. But your thoughts about what Isaac sort of teed up, that there's folks who maybe aren't engaged, and how to engage them, and are there ways in which the medical home or these interventions actually help with that?
So we, like many who chose that care transitions project, were really stymied by the small number but very high risk of patients, very difficult to engage. So the goal was to get people in at 48 hours. We had the appointment, we called them, we knew they were in, they were out, we had transportation, and we maybe only achieved 25% of people coming in at 48 hours. So I think that is a huge challenge that I'm not sure we figured out how to address.
I'll just also that that's one of the most important projects within DSRIP is around patient engagement, and there's a lot of money associated with it. So the extent to which you're involved with your PPS and you're involved with that patient engagement, it's about engaging low utilizing Medicaid patients as well as uninsured patients, and it's a big piece, as well as all the other projects that are around how do you reach out and get patients in the community, give them transportation, give them housing, give them mental health, and give them primary care.
Great. So in a minute, Erin's going to come up and talk a little bit about how we're going to feed your body and feed your mind with poster sessions and with some good food. But before we get to that, please join me in thanking Tom, Joanne, and Andrew.
So I have the fun job. I get to announce lunch. So before going to a poster or a showcase session, we urge you to eat here in the ballroom. And I just wanted to let you know we have 2 buffet stations set up. One is directly outside the room in the foyer, and one is in the Crystal Room. Please go to both to improve our flow and get people fed quicker. And following lunch, we invite you to enjoy the incredible poster sessions that are set up in the mezzanine area, and as well as the showcase sessions in the Crystal Room. And the DOH posters that Dr. Angelotti referenced earlier today in the data presentation are also set up in the Crystal Room, so you can have all your questions answered by our data analysts. Please try to be back in your seats by 1:55. Enjoy lunch, and thank you.